Good morning and welcome to this briefing, which marks the release of the July-August 2007 issue of Health Affairs. For those of you, and oh, by the way, I am John Eigelhart, the founding editor of Health Affairs. For those of you who work in the international arena and may not be familiar with the journal, it is a bi-monthly peer-reviewed publication published by Project Hope, an international health education organization. An independent editorial board oversees the journal, which derives a good bit of its support for publication from the major U.S.-based private foundations that invest in improving health systems in the U.S. and worldwide. Today, the journal is releasing its first thematic issue that is devoted largely to global health matters. This issue of the journal represents a marked departure from much of the content that we have published over our 25-year history. Over those 25 years, Health Affairs has devoted much of its space to issues facing the U.S. healthcare system. And today, as I say, marks somewhat of a departure. We have been publishing all along international content, but much of it has focused on the industrialized world. Today's thematic issue focuses on the health challenges facing low and middle income countries. We are indebted to the Bill and Melinda Gates Foundation for awarding the journal a 5-year grant to explore these and related health challenges that grip low-income countries because their resources are limited, their systems for delivering treatments are inadequate, and efforts of the industrialized world to come to their rescue fall short. With that, I am honored to introduce as our opening speaker this morning Representative Tom Lantos, Chairman of the House Foreign Affairs Committee. Congressman Lantos, a veteran of 26 years in the Congress, is the co-author of the 2003 law that created the President's Emergency Program for AIDS Relief. And he is and long has been a strong voice for U.S. participation in international organizations. Reflecting this belief, Congressman Lantos served as a congressional member of the U.S. delegation to the United Nations General Assembly in 1996 and 1997. Congressman Lantos.
Thank you very much. Well, let me say I have a choice of approaching the subject in one of 3 ways. First, I have the option of speaking to you as a professional economist who used to teach the economics of healthcare before any of you were born. Secondly, I can use a hat which I wear proudly. I have a very distinguished but very short medical career. I attended medical school for 1 week at the University of Budapest when they brought in the first cadaver and I switched to economics. Or I can speak as chairman of the House Foreign Affairs Committee, who is immensely delighted and proud that some years back my friend and colleague Henry Hyde and I succeeded in moving through a piece of legislation which is the largest global health initiative in human history. I will take the third option. The modern scourge of HIV/AIDS has stolen nearly 30 million lives, more than any war in human history except for the Second World War. The people gathered in this room know the statistics all too well. It is expected that there will be more than 4 million new HIV infections by the end of this year and nearly 3 million deaths. At this brutal pace, from now until this meeting ends, some 700 people will have died of AIDS around the globe. of those 700 lost lives, nearly a dozen will be children under the age of 15. The devastation from this virus goes far beyond those who suffer directly from it. It has caused massive upheaval to political, social, and cultural structures, including the most important one, the family. As a father and a grandfather, it disturbs me to no end that more than 15 million children worldwide have been orphaned by AIDS. These are utterly shattered lives. The cold, sober reality is that no assistance program can ever make them whole. But we can help prevent more children from being added to this long and dreadful list. On May 30th, President Bush announced his intent to double the funding for Pepfar from the existing budget of $15 billion to $30 billion over the next 5 years. And I commit to you today that as chairman of the House Foreign Affairs Committee, I will do my utmost to guarantee that Congress will reauthorize this crucial program at twice its present level. 4 years ago, my friend Henry Hyde and I labored long hours together to produce a strong bipartisan bill authorizing the President's emergency plan for AIDS relief. It provided for AIDS prevention and treatment programs in 15 of the hardest hit nations in Africa and elsewhere, establishing the United States as the world leader in the global battle against HIV/AIDS. And every time I hear yet another tirade of an anti-American political leader describing the United States as the great Satan, as Ahmadinejad does in Tehran, denouncing us as a selfish, self-centered, mindless, only money-interested group of people, it is my pleasure to point out that we provided, at a time of great domestic needs, $15 billion to help with HIV/AIDS in the poorest nations on the face of this planet. There is a great deal for us Americans to be proud of. It is inspiring to see how well this critically important program is working. It has supplied life-saving antiretroviral therapy to more than 1,100,000 adults and children, provided invaluable testing and counseling for 19 million human beings, and supported essential services to prevent mother-to-child transmission. These numbers represent solid progress towards the program's stated 5-year goals. But there is still a long way to go. The battle against HIV/AIDS is obviously a marathon and not a sprint. The current legislation rightly focused on providing emergency services in the war against HIV/AIDS, malaria, and tuberculosis. We decided to work on an urgent basis with governments and NGOs in the 15 most ravaged countries. But now we must make sure that these countries can maintain the momentum. That is why the next authorization will include provisions to transform the program from emergency to sustainability. This will necessitate additional funding for the target nations and better integration into existing health programs. As Congress moves to reauthorize this most important program, we will also carefully examine the effectiveness of our HIV/AIDS prevention efforts. We now know that for every person who is put on treatment, 6 people are newly infected. We have learned very quickly that we cannot treat our way out of this pandemic. We will have to focus substantial resources on evidence-based prevention programs that we know are effective. When Congress wrote the law funding Pepfar, some of our members insisted that at least 1/3 of the total funding for prevention initiatives be earmarked for abstinence-only education. Despite our strong reservations, my strong reservations, this 33% requirement was included in the final bill to get the necessary bipartisan support. But the Institute of Medicine recently reported that this provision has impeded the prevention arm from achieving its goals. The report states that sexual contact accounts for some 80 to 90% of new infections in Sub-Saharan Africa. Yet education on condoms and proper protection gets precious little funding. It seems that the famed ABC prevention mantra, abstinence, be faithful, use condoms, is distorted toward the beginning of that alphabet. Clearly, we need to and we shall revisit this 33% provision as the law comes up for reauthorization. We shall take a hard look at the consequences of this funding scheme and consider its wisdom. Congress now has the chance to revisit the ideological barriers providing comprehensive prevention services. The implementation of Pepfar has revealed a number of major challenges that will make it more difficult to reach millions who need services, particularly in rural Africa. Healthcare infrastructure either is weak or non-existent. Clinics, laboratories, and storage facilities simply don't exist, or are so run down and ill-equipped that they are of very little use. Shortages of healthcare professionals have been exacerbated further by the flight of many doctors and nurses to wealthier countries. Nutrition and basic household food production must be addressed as critical parts of treatment and care. Taking account of gender inequality, will be another aspect of our deliberations in drafting reauthorization. The AIDS epidemic has exposed the extreme vulnerability of women and girls to HIV infection because of cultural traditions, poverty, and economic inequality. It is ironic that marriage itself has become one of the places of extreme vulnerability for women because of marital infidelity. As we consider the future of Pepfar, it is clear that programs to educate, prevent, and treat are essential. But any serious discussion about eliminating HIV and AIDS must include the Holy Grail, the potential for a vaccine. It is imperative that we significantly boost funding to research promising experimental vaccines in order to save millions around the globe. The United States will step up its research efforts to help end this plague. All of this requires a major commitment and a tremendous investment of resources. But consider the costs if our efforts fail. The joint United Nations Program on HIV/AIDS reports that if the pandemic remains on its current pace, by the year 2015, in the 60 most affected countries, the total body count will be 115 million, which is equal to the combined populations of France, Australia, Austria, and the Netherlands. The United States Congress fully understands that considering its scope and scale, there is no work more important, no mission more imperative than beating HIV and AIDS. We will do all we can in the coming months and years to support that work to address the most urgent public health care issue on this planet. Thank you very much. I'll be delighted to answer a couple of questions because I need to get back to my day job. So go ahead.
Mark McCarty, Medical Device Dealer. Just one quick question.
Can you hear him in the back? Okay.
You mentioned something about doubling the Pepfar allocation. Are you saying doubling from 15 to 30 billion or doubling
That's
from
correct.
30 to 60 billion?
15 to 30 billion.
Okay, thank you.
Yeah. Yes.
A point of clarification, when you mentioned 115 million people there, was those people infected or deaths by the...
Infected.
Infected.
In the back.
Hi, Laura Iyama, freelance.
Can't hear you.
Laura Iyama, freelance Deutsche Welle. I'm wondering about, in terms of the fight over abstinence only, are you confident that you'll be able to reallocate those resources so that a third is not required to go to the abstinence only programs?
That's a very fair and very good question. I will do my utmost to revisit that issue, and I intend in the next couple of weeks to have one-on-one meetings with key colleagues on the Foreign Affairs Committee on both sides of the aisle. I am determined to readjust this allocation, and I am hopeful that we shall succeed. Thanks very much.
We will move right along with our next presenter, John Stover of the Futures Institute. I won't spend any time with the bios. You've got the information. These speakers are all well known in the global health community, I think, and I'll turn it over to John.
Thank you, John. I'm going to be talking about the paper called The Impact of an AIDS Vaccine in a Developing Country, presenting for myself and my co-authors, Lori Bollinger from Futures Institute, and Robert Hecht and Clara Williams Eva Rocca from the International AIDS Vaccine Initiative, IAVI. I guess I can throw out my introduction. I was going to tell you about the severity of the AIDS epidemic and the role that an effective vaccine could play, but Representative Lantos has done that much better than I could, so we'll skip right along. Anyways, he mentioned that today we still have 4 million new HIV infections every year, in spite of our efforts to date. Certainly, as we look to the future, we hope that we can reduce that number by doing a better job of scaling up the proven interventions that we have available to us today, as well as implementing new interventions. Male circumcision has recently been shown to be effective. That could be part of the answer in a number of countries, and research is ongoing for new approaches such as microbicides, pre-exposure prophylaxis, HSV2 suppressive therapy. So we hope that a combination of current prevention scaled up plus new technologies will certainly help us reduce this 4 million figure dramatically. But an AIDS vaccine could be our best hope. Over the past 10 years, there has been progress. Today, approximately 25,000 volunteers are participating in more than 30 vaccine trials throughout the world, in about 24 countries around the world. Political and financial support for AIDS vaccines is growing. But we have to recognize that the first vaccines that become available for implementation may not be the perfect vaccine that we all probably have in our minds. It's probably not going to be 100% effective, which is what we all want a vaccine to do. In fact, the first of vaccines to become available may not even protect the person vaccinated from infection. Their mode of action may be to change the progression of the disease once a person becomes infected, to slow the progression of the disease so that it becomes more of a chronic infection than an acute one, and also at the same time reducing infectiousness. So this is a mode of action that's different from what we're used to thinking about with vaccines, and it certainly raises some questions. So in an effort to understand the potential effect of partially effective first-generation vaccines, Futures Institute and IAVI have undertaken a study to look at some scenarios. What would happen if we had vaccines available with different characteristics and implemented them into current programs? Our purpose in undertaking this work is to obviously build an understanding and use that understanding hopefully to enhance the political and financial support among the international community, but also to help developing country leaders and stakeholders to understand the potential impact of an AIDS vaccine on the epidemics in their countries in order to build their understanding and support for vaccine development efforts. So we really focused on four major questions. The first one will a vaccine that has less than perfect efficacy still be useful? Suppose the vaccine has only 50% effectiveness. Is that still something that we would want that would have a public health benefit? And it's also important to point out that vaccines can have different modes of impact. When I say 50% effectiveness, what does that mean? Does that mean that if we vaccinate 100 people, 50 of them will be fully protected and the other 50 will receive no protection? Or that all 100 will have their chance of becoming infected reduced by 50%? Those are two different ways of action, and at the global level, it may not make so much difference. But to the individual, of course, it makes a huge difference. So that was one question we wanted to look at. Would a partially effective vaccine still be useful? Second is, we don't have a vaccine today. Candidates are moving through the different trials. The earliest we might expect one is, let's say, 2015. If we don't have an AIDS vaccine until 2015, will we still need it then? With all of our efforts to scale up prevention to universal access well before 2015, will we still need an AIDS vaccine at that time? Thirdly, would a vaccine still be useful if its mode of action is not to prevent acquisition of a new infection, but to delay the progress of the infection in the infected individual and to reduce infectiousness? And then fourth, of course, the big question is, would an AIDS vaccine be cost effective? So our approach to looking at these four questions was to develop a computer simulation model, a model that could be easily applied to developing countries with readily available data that we have today that can replicate the historical pattern of the epidemic in those countries, and that could allow us to examine questions about these different vaccine characteristics, level of efficacy, type of action, different levels of coverage, different durations of effectiveness. How long will the vaccine be effective? So we've developed this model. I'm not going to spend any time talking about the details of the model here today, but it is, there's some information in the paper. There's our other background papers that are available, and the model is also available for downloading from our website for those that are interested. We then applied the model to 7 large epidemiologically important countries in Sub-Saharan Africa, Nigeria and South Africa, in Latin America, Mexico and Brazil, in Asia, China and India, and in Eastern Europe, Russia. These countries together account for a little less than half of all current infections and about 2/3 of all new infections. We set up the model so that the base projection would match the historical trend of the epidemic in those countries, and then we projected it forward to 2015 and actually beyond that to 2030. In projecting it forward, we've made the assumption that current efforts to scale up universal access to prevention will be successful. So we're assuming scale up of prevention by 2015. Then we examined various vaccine scenarios. In all cases, we assume the vaccine becomes available in 2015 and reaches full target coverage levels by 2020. That the vaccine has a duration of effectiveness of 20 years, that it doubles the progression period with HIV, and that it acts on both susceptibility and infectiousness. We created 3 different scenarios to look at sort of low, medium, and high, or pessimistic, medium, and optimistic scenarios. In the low scenario, we assumed that the vaccine has only 30% effectiveness, and that coverage would be only 20%. So this is a very sort of at the lower level of what might be acceptable, only 30% effectiveness, 20% coverage. The medium scenario assumes 50% effectiveness and 30% coverage. And the high one assumes 70% effectiveness and 40% coverage. By 40% coverage, I mean that 40% of the target populations would receive the vaccine. In generalized epidemics, this would probably be the entire adult population. In concentrated epidemics, it could be either the entire adult population or it could be focused on those populations with most risks. So we used the model to examine these scenarios in the 7 countries, and then we scaled up the results to indicate the impact in the low and middle income countries in general. One of the charts in your press kit shows you the major results. This particular chart shows you the annual number of new infections expected in low and middle income countries, starting back in 2000, projecting forward to 2030. With the year 2015 being an important year in this chart because it is both the year in which universal access to current prevention and ART treatment is achieved, and also the year in which the vaccine becomes available. So there's some important kinks in that chart. The top red line shows you a projection of the number of new infections that might be expected every year without the vaccine. And you can see it's roughly constant there at about 3 million a year. And then the lines below that show the impact of the vaccine, the low, the medium, and the high vaccine scenarios on reducing the annual number of new infections. Overall, this indicates that the vaccine could avert between 6 and 28 million new infections during the 15-year period from 2015 to 2030, which is about 20 to 80% of all the new infections that happen during that period. So about 1/5 to 4/5 of all infections. It would avert 3 to 9 million AIDS deaths during that period. And by reducing the number of new infections and therefore reducing the future need for ART, the vaccine would avert between $30 and $130 billion in future treatment costs. Now, it's difficult to answer the question about whether a vaccine is cost effective because at the moment we don't really know what a vaccine will cost because we don't have one to try out yet. But our modeling shows that depending on the scenario, we would have to vaccinate between 15 and 30 people in order to avert 1 new HIV infection. So if the vaccine costs $100, that would be $1,500 to $3,000 of expenditure for every infection averted. That's similar in many ways to the other prevention activities that we currently have available to us, and of course much less than the expected future treatment costs of somebody who becomes infected, which the discounted current value of future treatment is probably in the order of $10,000. So it's possible that a vaccine would be cost savings, not just cost effective. So from this work, I'd just like to briefly mention 6 conclusions. The first one is that even a low efficacy vaccine could have a significant impact on the future of the epidemic. The second one is that vaccines will still be needed by 2015 or even 2020. So we shouldn't give up the search because we're still a number of years away from having useful candidates. A third conclusion is that even if the major activity of the vaccine is the slow progression and reduce infectiousness, it will still have a major impact on the epidemic. And this is a vaccine that provides a public health benefit. The benefit to the individual is not preventing the acquisition of the infection, but slowing the progression of the disease so that instead of progressing to AIDS and death in 10 or 11 years, that period is stretched out to 20 or 25 years. And of course, with ART, could extend the life expectancy of somebody with HIV much, much longer. The number of vaccinations required every year to achieve these targets and the total cost will depend on targeting strategies, and those will vary quite a bit from country to country. Our results are based on a pretty optimistic scenario about the scale-up of other prevention and treatment activities. If that scale-up is slower, the number of new infections would be even higher, and therefore the impact of the AIDS vaccine would be even larger. Finally, even though the cost of a vaccine is unknown, given its large impacts in reducing new infections, AIDS deaths, averting future ART treatment needs, and all the ancillary impacts that come from that, such as preventing children from becoming orphans, that even though we don't know what the cost of the vaccine would be today, it seems quite clear that at any reasonable cost, it would be a very cost-effective program. So those are the results of our study to date. Our next step is to work with national researchers in low and middle income countries to apply the model specifically in those countries and examine the impact of the vaccine in those countries. We've already started this work in Brazil, Uganda, and Kenya, and a number of other countries have also asked to be included in the future phase of this work. So as we go forward with that work, we'll be examining the impact of the vaccine on the specifics of those epidemics and helping country decision makers and stakeholders to understand how vaccines could affect the dynamics in their countries. Thank you very much.
Thank you, John. We'll take questions of all the panelists following their 3 presentations. Our next presenter is Philip Musgrove, a health economist and deputy editor for Global Matters at Health Affairs. Philip was really the main person responsible for putting this issue together, and he is always in search of manuscripts. So if any of you have work you'd like us to consider, we would certainly welcome it. Philip was one of 6 authors who addressed the subject of catastrophic health spending, a global perspective. Philip?
I'm the 6th author and the one who did the least work for this paper, but it would have cost a ticket from Geneva to bring any of the others over here. So they have graciously agreed that I can present the work of which they did the major part. Usually, papers like this tell you what we found and then tell you all the reasons to be a little cautious of interpretation. We put all the limitations at the end of the paper. I'm going to put a few of the limitations up front so it's very clear what we're talking about here. One is that catastrophic spending is a rather slippery term. It depends, you've got to have a definition, depends what definition you pick. The definition is very carefully explained in the paper. What it comes down to saying is that spending on health for yourself or your family is catastrophic if it uses up more than 40% of what's left over after getting enough to eat. That's a pretty rigorous definition. That's really enough for anybody to feel pain from. You could move that threshold up or down, and it would clearly change the numbers of people who appear to suffer catastrophic spending. So this is arbitrary and at the same time, I think, quite reasonable. Second thing is, these aren't surveys. This is all based on survey data, and in fact, you can go to the website and find the descriptions of all the 116 surveys in 89 countries. You can see there the actual numbers, which are not published in the print version. It simply takes up too much room. And we have one editor who is a real tigress about not letting us waste too much room on any one paper. But it's all there. It's all available. The surveys weren't taken by WHO. All these other authors are from WHO. These are surveys that were available and could be used, and they have one interesting limitation. They weren't all done at the same time. So we don't have a snapshot of the world. When we take an average and say that roughly 2% of all households seem to suffer catastrophic spending, we're not saying that happens at the same time. We don't really know. We don't know the full distribution through time. What we do know, and it will be very interesting if you compare the results for the same country in different years, is that the danger from this problem of financing things out of pocket fluctuates with economic conditions. These aren't stable characteristics of the countries only. These are very, very responsive results to economic conditions. When an economy goes into high gear, more people get jobs, more people get insurance, people have more money. The government typically has more money to spend on healthcare. The result is that catastrophic spending goes down. Everything goes into reverse, of course, when the economy goes into reverse. And one of the problems that these data show, as a matter of fact, is how sensitive the risk of being broke from healthcare spending is to economic conditions, even though the economic conditions themselves aren't described in the paper. The downturn of an economy is a very serious risk for millions of people because they lose their jobs or lose insurance or have their income fall or have all this happen at the same time that government spending to protect them in healthcare is being pulled back. So that's an important point to notice, and if you make comparisons where we have data from the same country for 2 or 3 or 4 different years, you can really see this. The catastrophic share often varies by a factor of 2. Another thing to point out is we're taking a very limited view here of a catastrophe. We're talking about the catastrophe of having to spend more than it looks like you can afford. That doesn't say anything at all about 2 other forms of catastrophe. One is having your health deteriorate to be, for example, unable to work, even though you spend the money. We don't know the health outcomes for these people. We assume that when they spent the money, that's because they got some kind of care, but how effective it was, we don't really know. That's a whole separate issue. And the other thing, of course, is these are all the people in these surveys who actually did spend catastrophically on care. All the people who took a look at at their budgets or looked under the mattress for the money and thought how far it was to the nearest clinic and didn't go for care may have suffered catastrophe because they were left sick or injured or unable to work. So we're only looking at one side of this. It would be very interesting to put the 2 together, but that's hard to do. You can get questions to people in a survey about why didn't you get care when you thought you needed it? And that often shows that cost is the major barrier and is very, very income sensitive. In fact, that's practically inescapable. And finally, we don't know something that I think it would make this problem look a lot worse than it does, and it looks bad enough already. These are one-time surveys. These are asking what happened to you in the last month, or maybe for hospitalization in the last year. Well, if somebody suffers a catastrophic expense this month and gets over it somehow and gets the care he needs and next month begins to get back on his feet, you could say, well, all right, this is a little turbulence in economic life. This is too bad. But it's not really catastrophic. That's an exaggeration to call it that. But what if it's a chronic condition? What if it's something if they don't keep spending, they're going to die or be crippled and unable to work? What if this is something that maybe doesn't cost 40% of the non-food budget every month, but it costs 25% month after month after month? What if it means that when you've run out of the cash in the house, you have to sell the only cow or you have to sell the land to pay for it? We're underestimating catastrophe in every single one of these dimensions. I wish I could scare you with the exact numbers. I don't know what they are, but it's a lot worse than we're saying here. And it's bad enough already. Now, what have we actually found given all of these limitations? What's the sort of minimal estimate of how bad this problem is? That's one question. Second question is, how is it distributed around the world? Third question is, what does this have to do with the way the health system works? And finally, what factors seem to be explaining this? Because after all, this is written by a bunch of economists, and after they think they find something, they always try to explain it. So you have in your press kit this sheet with 3 things taken out, 3 exhibits taken from the article. Let me talk you briefly through those 3. Say this is not the exhibit that shows the actual data, but you can look that up on the website. Exhibit 2, which is at the top of this one-page handout, shows you the distribution of these estimates of the percentage of households that suffered catastrophic spending as recorded in a survey in a country. The unit really here is the surveys, not the countries. Most countries had just one survey. When the countries are divided up into low, middle, and high income groups, what you see immediately, and it's not the least bit surprising, is that the problem is worst in the low-income countries. There's no surprise in that at all. The problem shrinks as you go to higher income countries, but it doesn't disappear. You still have some observations of around 3% of households being hit with what we think of as unaffordable spending for health care, even in high-income countries. It's not because there isn't enough money to go around, obviously. It's got to be something about the way that health is paid for. You go to the lowest income countries, and right in the median, you're now talking about more than 3% of households being impoverished in each survey, and a maximum that goes up to around 10%. That's an awful lot of people to be hit with this kind of economic damage. It may be very small in money terms, but as a share of their income, it's quite enormous. It's mostly the upper end of this range that varies so much with income. The lower end of it, the pale gray square on the left-hand side, doesn't show that much difference according to income. But even so, there's some difference there. It only gets squeezed down near zero in the highest income countries. Exhibit 4, the next one down here, asks, what difference does it make how healthcare is principally paid for? Because after all, the crucial distinction here is you can only be impoverished, you can only suffer catastrophic spending if you're paying for it out of pocket. So on the one side, you have out-of-pocket spending, some of which is perfectly reasonable and some of which is not affordable and catastrophic. And you have everything else, which we've learned to call prepayment. That means to say you have either some kind of fairly explicit insurance, or you have social insurance, or you have the government paying for your health care, or some level of government. And the question that naturally comes up is, does it matter what kind of prepayment? It obviously matters whether it's prepayment or out-of-pocket, but does it matter what kind? Because there is an endless argument, it goes back decades, whether it is better to have government pay through taxes or to have insurance that's usually tied to employment, what is called social health insurance and abbreviated as SHI here. And it happens that a lot of the health systems in the world are some of one kind and some of the other. So there's also a category called mixed. It turns out that when you look at this, you can't see a very strong systematic difference. It looks like maybe the worst extreme levels come under the social health insurance, but that's not really different from the tax base. If you look at the median, it's also higher in social health insurance. But the interesting thing is how wide the spread is under both of these. There's no evidence here, in other words, of the right way to finance prepayment. The overwhelming message is prepayment beats out of pocket unless you're talking about very small expenses. Now, this is something that's kind of hard to get across to some of our economist friends, because for most things in the economy, paying out of pocket is a sensible way to go. You make your budget, you decide what you can afford, you pay small amounts or large amounts, you decide how to finance it, and you don't expect insurance to cover it. We pay for food that way, after all, and food is a lot more important than even health care, although we can't say that in some public health circles. But what we do know is that we're talking here about insuring an asset, and this asset unfortunately doesn't work like your house or your car at all. This is an asset that can't be replaced, that can't always be fixed when it breaks down, that can cost catastrophic amounts of money, and therefore insurance of some form is absolutely crucial to protecting it. And what we're seeing with these high rates of catastrophic spending is a lot of people aren't getting that protection. The rounded up estimate for the number of people affected on average in a given year by this runs to something like 150 million. It's a lot of people. It's not as bad as the damage from AIDS, but it is very damaging, and it exposes people to very high risks. Now, what is it that accounts for these differences? The Exhibit 2 and Exhibit 4 just tell you very quickly the kind of spread that we found in these numbers. What is it that they're related to? Can we draw on anything other than just the fact that out-of-pocket payment is where the risk comes from? Exhibit 5 at the bottom of the page is a lot of numbers. You don't have to pay attention to all of them by any means, although they're worth some study. My co-author split this up by the low, middle, and high-income countries again, and then did something else interesting, which is to look at the middle-income countries where prepayment is at least half of total spending. This is a very different group of countries from those that have some kind of system, but they're covering less than half of the total. So if you go down, for example, the p-value column under prepayment more than 50% of total spending, what you find is that every one of these possible factors is significant, at least at a 10% statistical level. But rather than go down columns, I'd like to draw your attention to rows. Take a look at the second row labeled Gini Coefficient. That's the coefficient on the concentration of income in the country. And the bigger that number is, the more unequally income is distributed. And take a look at the last row, the prepayment share in total health spending. Each of those factors is highly significant all the way across, except that income concentration doesn't matter that much on average in high-income countries, and that's because high-income countries, except for this one and Switzerland, generally have quite thorough coverage either through taxes or through social health insurance, or both. These are the two factors, in other words, that in general, and leaving out to some extent the high-income countries that aren't our main interest, these are what really drive catastrophic spending. One is very unequal income, not surprising. Poor people have a much harder time paying, and remember that the catastrophe is defined relative to a household's own income and spending. So the fact that there's plenty of income on average makes no difference. And the prepayment share in total health spending is highly significant. The more that prepayment covers people, the less risk there is of catastrophe. That's kind of intuitive. It's not the least bit surprising, but it's nice to see it demonstrated. That's what pushes down the catastrophic share quite considerably. If you look at the numbers under coefficient, this says that raising prepayment by just 1%, 1 percentage point, raising it, say, from 50 to 51%, in poor countries, on average, knocks 1.3% off the number of households that would have a catastrophic spending. In other words, it's highly, highly sensitive to this. This is not just intuition. This is a very, very strong relation. Those are the main results of the paper, and the main message, I say, is pretty simple. Prepayment is what is needed, not necessarily for 100%. There's no argument that insurance ought to cover every single thing. It ought to cover the catastrophes. It ought to cover the high risks. It's okay if everybody or almost everybody has to buy his own aspirin. The catastrophic level varies. For some people, it's $5. For some people, it's $50. For us in this room, it's probably upwards of $5,000, certainly at least $500. But the point is, very low cost items we can afford to pay out of pocket. Even fairly poor people can and do. It's the catastrophic spending that we'd like to see eliminated. So one interesting question, this goes a little bit beyond what is in the paper, but I have been playing with this for the purpose of another paper, so with your permission, I'll tell you a little bit about that. How much would it cost to buy out, in the typical case described here, the catastrophic spending? Suppose you could go around to these households that suffered this high level of spending and compensate them for the amount that went beyond the catastrophic level. Let's say a family spent 60% of their non-food expenditure on health care, and you could somehow give them back 20 so they'd be right at the catastrophic level. How much money are we talking about? Is this something the world can afford to buy out or not? Well, the answer is that for the typical household that did suffer a catastrophe, taking it across all these countries, which means a heavy concentration on the low and middle income ones, we're talking about, on average, about 10% of their income. Actually, we measure this as consumption, but let's call it income because it's easier to think of. In other words, 10% of the consumption of those households, who are typically 2, 3, 4, 5% of all the households in the country, multiply those two numbers together, and you get a very small fraction of total spending. So the argument that a country couldn't afford to buy out the catastrophic spending just doesn't hold water. It's a very small share of total health spending, and it's a much smaller share of total income in the country. The catch is to make that work by having a prepayment system, whether it's taxes or social insurance or some combination of them, that can somehow keep total spending under control. Because, of course, we don't have a way to go around and give 10, 20, or 30% of their income back to those households that happen to suffer catastrophe. That would be a sort of indemnity insurance, and that's much harder to set up, and we'd have to make sure that people weren't cheating on their claims and so on. Suppose then that we talk about making the price of health care low enough through subsidies of various forms or through insurance that nobody ends up spending anything catastrophic. We'd be talking about a much larger share of total income. So there's no argument here that says we could just switch this money around a little bit. We could just somehow chip in and cover the catastrophic part, and total spending wouldn't have to rise. Total spending would rise, and it ought to rise, if what we're trying to do is make sure that nobody suffers either a health catastrophe or a financial catastrophe. But the part that is purely catastrophic is still a very small share of total spending. The arguments, in other words, why this isn't happening are partly the poverty of governments, their difficulty of raising taxes, partly the administrative difficulties, but they're not, by and large, arguments that there just isn't enough income available to finance it. Except in the very poorest countries, And it's in the very poorest countries that the problem is worst, and it's in the very poorest countries that the question of foreign assistance of one form or another becomes urgent, as Amanda will talk about next. One last observation, you might wonder why I'm comparing here social health insurance and tax-based funding, and there isn't a word about private voluntary insurance. I mean, that's also another way of financing prepayment. And the answer is pretty simple. It comes in two parts. First of all, most of the countries studied don't have any significant amount of private health insurance. They either just don't have an industry of it, or they don't need it very much because they've already got social health or tax-based insurance. And secondly, that's not a solution for poor people anyway. Poor people can't afford insurance adequate to cover the risks that they face. Poor people mostly don't drive cars, so they don't need car insurance. They mostly live in houses that don't cost very much. If they wanted to insure the value of their dwelling, they could probably afford it. It'd be some fraction of it. The trouble is that bodies, unlike houses and cars, are very expensive, and they're about equally valuable whether you're rich, poor, or in between. So private insurance as a solution just isn't on the board here. It's a question of how to get enough prepayment. It's a question of buying out the catastrophic spending, and incidentally, that would head off the other elements of catastrophe that I mentioned, which the paper is unable to cover. Thank you very much.
Our next presenter is Amanda Glassman, who is Deputy Director of the Brookings Global Health Initiative, and we welcome her.
Thank you. Well, we've heard a little bit about the disease burden facing poor countries, as well as the impact of catastrophic out-of-pocket spending. And our paper, with my co-author Chris Lane, tries to answer the question of how have the wealthy countries, the OECD countries, responded to help poor countries meet these challenges? Well, it's quite well known that since 2000, the wealthier countries have responded quite decisively. Aid for health has grown by 60%, and disbursements have more than doubled between 2002 and 2005 alone. This growth reflects new players like the Global Fund on AIDS, TB, and Malaria, but also major increases in commitments by the bilateral donors like the United States through Pepfar, which we heard about this morning, as well as the European Commission. And it is these investments in health that are driving the increase in overall development aid. But aid priorities have changed during the scale-up. Spending has shifted towards prevention and treatment of communicable diseases, including HIV/AIDS. Between 2002 and 2005, the increase in disbursements for communicable diseases, including HIV/AIDS, is about half, more than half, the total increase in health aid over the period, which confirms an earlier hypothesis in the literature that AIDS spending is crowding out spending on other priorities, such as family planning and reproductive health. And this spending shift also reflects an important shift in the type of spending, from predominantly infrastructure and equipment to an emphasis on financing recurrent spending, medicines, and human resources. But in spite of these important increases, unmet needs still are huge. They represent between 30 and 70 billion a year, depending on who you ask, which is about 9 to 20% of current health spending in developing countries, and about 3 to 8 times the current amount of aid for health. And even though this amount is small with respect to global GDP, less than 0.1%, there's still concern that this upward trend isn't sustainable, in part due to the disappointing results that we've been seeing after the Gleneagles Summit and the fiscal positions of the major donors. And there are major concerns around the efficiency and the effectiveness of health aid. Probably you've seen last week's Economist, which ran a piece that was titled "More Money Than Sense," arguing that health aid increases may be, in the Economist's words, making things worse. Our paper looked at the empirical record to determine whether aid funds are indeed aligned with recipient disease burden and with their priorities, and explored whether things were getting better or worse over time with respect to measures used in the literature to judge aid effectiveness. And where possible, we tried to pinpoint the guilty parties. Are the new global health partnerships, the so-called innovative financing in the field, really making things worse? Or are other culprits to blame? So we first looked at how well money tracked to needs. Second, whether aid was delivered efficiently. Third, whether its time frame tracked to recipient requirements. Fourth, whether financing was volatile and unpredictable. And finally, whether the fragmentation of assistance, that is the number of different actors giving funds to any given country, is improving or not, which has a big impact on transaction costs associated with aid. So what did we find? Assuming that the central objective of aid is to improve health, which is a big leap, do donors allocate funds to recipient countries on the basis of their health needs, taking into account the many other factors that might affect health aid, such as whether aid funds are likely to add on to or substitute for recipient spending, the size of the population of the country, whether countries have the capacity to use that aid effectively, the governance conditions, as well as country commitment to improving health outcomes as measured by health spending as a percentage of general government spending. And here it's interesting to note that the general aid effectiveness literature finds a very weak relationship between aid and poverty. That's the work of Easterly that you might be familiar with. We found that health aid is positively associated with disease burden. A 1% increase in disease burden is associated with a 1% increase in health aid per capita. Aid also responds positively to improvements in governance and economic freedom. That's the good news. We're doing better than the rest of aid. But the population size of recipient countries affects the amount of aid that they receive on average. Larger countries get less aid, independent of their income. And that's a finding that has implications for the cost effectiveness of our aid investments. We also looked at the relationship between specific disease burdens and aid per capita. Only HIV/AIDS and TB disease burdens are positively and significantly associated with aid per capita, after allowing for the other effects of commitment, governance, income, and population. So the big communicable disease programs, the global health partnerships, seem to be getting the allocation right, and the rest of us are not doing as well. But even if aid tracks to some health needs, the question is, what, if not necessarily country priorities, which I'll come to later, is it delivered efficiently? Tying aid to goods or services from a given country or set of country is recognized to reduce the effectiveness of aid. That's the other aid. UNDP reports that price comparisons find that tied aid reduces the value of aid by up to 30%. So although the practice of aid tying has declined over the past decade, geographically tied aid still remains 1/5 of total health aid in 2005. And unfortunately, the United States does not report to the OECD on this measure. And we know that US aid is predominantly tied. This implies a minimum efficiency loss then in the range of around 200 to 300 million per year. The Global Fund and Gavi follow best practices. They untie aid, they do their procurement worldwide. Another way to look at the issue of alignment is to explore whether aid is aligned to recipient priorities. The proxy that's used here is whether aid goes directly to government budgets, which is definitely a controversial measure, but we can discuss that during the question and answer. You might know the case of Rwanda, where 40 million a year is going to HIV/AIDS prevention and treatment, but only 1 million is going to maternal health and the integrated management of childhood illnesses. So the lack of connection to country priorities can affect the allocative efficiency of aid at the country level. And in spite of international calls through the Paris Declaration of the OECD, since even before that in the 1990s, budget support still only represents about 12% of total health aid. Now, do the time frames of the financing of donors help or hurt? The extent to which donors are able to pre-commit aid over multi-year periods to sustain scaled-up financing for service provision is a key element of health aid effectiveness. In poor countries that have small, formal taxable economies and weak revenue bases, the transition away from aid financing is likely to be long-term. The majority of aid agencies, with the exception of a few UK DFID programs, Gavi and the Global Fund, continue to commit grants to countries for 1 to 3 years for current spending and 5 to 6 years for project aid. Another aspect of duration relates to the terms of financing available to aid agencies themselves, which affects their ability to turn around financing on good terms for their recipients. Unlike Gavi's regular financing window, which relies on irregular donor contributions, the launch of the Innovative Finance Facility the International Finance Facility for Immunization provides a guaranteed flow to Gavi for a 10-year period. On the other hand, the Global Fund faces constant struggles to replenish its funding, or did prior to their last replenishment. For example, a July 2006 Global Fund donors meeting was discussing how to fill almost a $1 billion gap in financing for the second half of that same year. Even when funds are already approved, that financing is volatile. With shallow domestic financial markets or high levels of overall indebtedness, many low-income and some middle-income countries have inadequate reserves to cover their own revenue volatility, much less shortfalls in aid. And health aid is very volatile, with an average absolute percentage deviation from trend of almost 20% over the past decade. And the volatility of aid for health is double that of government spending on health. Now, volatility might not be a problem when you're financing infrastructure, but when you're financing recurrent spending on tuberculosis medications, for example, such flows could really be disastrous. It could affect the longer-term efficacy of treatment. You might have problems retaining staff, et cetera. So when we try and compare predictability and volatility between traditional and innovative financing sources, it's a bit difficult because most of these agencies don't necessarily make public their planned phasing of disbursements. But we went ahead anyhow and compared disbursement rates on the World Bank Health Sector portfolio with the Global Fund's grant portfolio, considering only projects and grants that were active at the end of 2006. We looked at the dispersion of disbursements around a linear time trend as an indicator of volatility. Global Fund grants are intended explicitly to have a more linear drawdown of grants dispersed at regular quarterly intervals, consistent with their mandate to provide antiretroviral treatment, for example, while World Bank projects are not explicitly intended to disperse linearly. But on average, Global Fund grants are 90% dispersed at the scheduled end of grant, compared to about 80% dispersed for World Bank projects. Both pretty good results for both agencies, particularly the bank that accounts for disbursements ex post, after the fact. So the available data suggests that performance-based innovative financing from the Global Fund has not markedly reduced the predictability of aid in comparison to one of the largest sources of traditional health aid. A final hot topic has to do with the plethora of actors in the global health field. Health suffers from acute aid fragmentation, meaning many donors in a single country, but also donor proliferation, meaning donors that work in many countries, which raises transaction costs and decreases cost effectiveness. Of the 28 bilateral and multilateral agencies that disperse to the health sector and report to the OECD, 15 are active in 43 or more countries. Just to illustrate, Cambodia receives approximately $60 million in donor disbursements from 14 active bilateral donors and at least 5 multilaterals, and over 100 NGOs are active in the health sector. Predictably, the Ministry of Health in Cambodia receives over 400 visiting donor missions per year, and that's in a very low capacity setting. Within recipient countries, the health sector is significantly more fragmented than aid for education or agriculture during the 2002-2004 period. And fragmentation is increasing in health, while stable or declining in other sectors. It's the coexistence between the multilaterals, the global health partnerships, and the extensive bilateral health aid programs that raises the premium for more focused support at the individual donor agency level. The differences in aid proliferation across donors suggest that many of the major donors could develop a more geographically focused approach to health aid and contribute to reduced aid fragmentation and improve the efficiency of aid delivery, particularly among what we're calling the high proliferation second-tier donors in terms of aid volumes like Japan, Spain, France, and Germany. Some aid recipients and donors have made efforts to address fragmentation issues. Some 20 countries are implementing pooled funding for, budget support. And these pooled funds, called sector-wide approaches, or SWAP, are concentrated in the countries that do have the highest levels of fragmentation. But as we've seen, these budget support programs are still a very minor share of total health aid, and relatively few donors participate. To conclude, against a backdrop of rapid growth in health aid volume, there is still considerable scope to improve the terms of aid and its efficiency. The good news is that aid for health does respond to recipient aggregate disease burden, to recipient capacity, to their commitment to health as expressed through their own spending, and to the quality of governance. But we find that health aid is overly targeted on small countries, and the criteria and cost effectiveness for allocating among disease and condition-specific interventions is not well developed. So improving health outcomes will also depend on improving the terms of aid delivery. Too much of health aid is still short-term, volatile, unpredictable, tied to specific countries, and highly fragmented. How does innovative financing fare? Pretty well. They perform well on some key aid efficiency parameters. They've extended the duration of their support. They, in some cases, analyze longer-term financial sustainability issues, as in the case of Gavi, and they support alignment of aid with disease burden in the case of HIV, AIDS, and TB. But it performs less well on other measures, namely alignment with recipient country priorities and aid tying to particular technologies or diseases. And the new innovative financing institutions complement rather than replace traditional mechanisms, thus increasing aid fragmentation. As we've seen, Global Fund performs about the same as the World Bank on volatility. Since both the global health partnerships and the multilaterals like the World Bank perform well with respect to some key financing parameters, to reduce the high costs of aid fragmentation, it's the bilaterals that need fewer but larger country programs. And they need to untie their aid and channel their scaled-up financing through existing instruments such as Gavi and the Global Fund, or multilaterals such as the World Bank. All aid sources that finance recurrent costs under favorable terms. And a key example here is Pepfar. Welcome new funds for the fight against AIDS, TB, and malaria, but run almost entirely through US contractors and within countries predominantly off-budget. Shortfalls in financing for global health priorities and the long-term horizons for sustainability suggest that the efficiency of the marginal dollar of aid is as important as ever. So we should assess new proposals ex ante on their capacity to meet the financing needs of developing country governments and partners, not just on magnitude, but in alignment and terms. Thank you.
Thank you, Amanda. The floor is open for your questions and comments. I would just ask the individuals who are in the overflow room, if you do have questions, if you'd bring the questions up to the front here, and we would distribute them to the panelists. So the floor is open. Yes, sir.
I have a question for John Stover.
Could you identify yourself too, please?
Sorry,
Thanks.
Jeff Barnes, Apt Associates.
Thank you.
Question for John Stover. Excuse me for having a short-term view, but I'm actually quite interested in your scenario for 2000 to 2015. What scenario assumptions you made there, and whether in the scale-up you assume that as more people go on ART and they're living longer, what's the impact of that on prevalence? And did you assume that prevention efforts will be as effective as treatment or less at treatment? In other words, are we potentially making the pool of infected people larger rather than smaller from now to 2015?
We're going to answer now?
Yeah.
Yeah, thanks for your question. Well, for 2000 to 2015, on the prevention side, we assume that the scale-up of the coverage of interventions, such as counseling and testing, programs to prevent mother-to-child transmission, condom distribution, AIDS education, et cetera, that the coverage would scale up to universal access levels, which is generally 80 to 100% coverage of those in need. We have a separate model that includes an analysis of the impact research literature that tells us how behaviors change when people are exposed to each of those different prevention interventions. And on the basis of that, we modeled behavior change, and then from that, the impact on new infections. So we have lots of papers on it. It's rather complicated to explain briefly, but so we tried to make the best available use of information today. The impact of ART on prevention is a difficult one. Yes, ART keeps people alive. So people who are HIV positive are kept alive longer. Many are returned to sexual activity. So it has the possibility of increasing new infections, but also the treatment on antiretrovirals reduces viral load significantly. So we expect that there would be few new transmissions because of antiretroviral therapy. Bigger question might be one of how that affects behavior. Do people tend to adopt riskier behaviors because they think antiretroviral therapy is available? A similar question for vaccines, of course. So far, I think the evidence is that we haven't really seen that in the developing world, so we're not including it so far.
Yes, sir.
Thank you, John Glassman, Northrop Grumman Corporation.
And you can just repeat the question.
In terms of needs and areas of defense and so forth, we have a formal requirements process. We have committees in Congress that look at the efficiency of spending as against these requirements. Should there be something similar in the health area for universal needs? In other words, should there be some type of objective formulation or evaluation of each year of global health needs, and then the responsiveness of donors, whether multilaterals, bilaterals, to the satisfaction of these requirements?
Well, I think that we'd probably want to ask our political scientist colleagues. But yes, ideally, but the way that, of course, you know that the aid budget is developed in the U.S. Congress is not necessarily a process that considers all of the available alternatives for allocation and structuring of that finance. There's a lot of things at work, and maybe those of you who follow the legislative agenda more closely could comment on that.
I could, not from the legislative agenda in the U.S., but globally, I can tell you that there are a number of disease-specific efforts to estimate global resources required. In the HIV/AIDS field, this has been done every other year since 2001 as part of the UNGAS. And this year, later this year, WHO is going to be publishing in the WHO Bulletin what they call global price tags, which are estimates of the total resources required for 5 major health requirements. So there is information available about the total resources required for a large number of health fields, not all, but a large number.
Yes, sir.
I'm Mark McCarty of Medical Device Daily again. I have seen numbers that indicate that the death toll from malaria in Sub-Saharan Africa is higher than that of AIDS, and I don't know whether this is also true of Southeast Asia, for instance. But between that and the fungibility of monies that are donated to some countries, is that driving a greater interest in infrastructure and maintaining salaries for doctors and nurses in some of the poorer nations, and draining a little bit of emphasis on disease-specific situations? Where's the discussion on that in the healthcare community? Anybody care to answer?
Go ahead.
I can say one thing about that. One of the impetus behind this global price tag series of articles that WHO is releasing later this year is specifically to look at the needs for strengthening the health systems within countries. Because if each disease comes with its own priorities, AIDS comes and says, well, we need this much money and we need this many doctors to provide this level of treatment. Each one of these different price tags is sort of depending on a health system to be there to deliver these services if we have the money. So part of this effort was to estimate the burden on the health system and the strengthening that's required, both in retaining current health personnel, training new ones, providing incentives, improving infrastructure. So part of this global health price tag is a fair share that the resources devoted to each disease need to be contributing to strengthening the overall health system. So it's being addressed. I'd say we're still, it's still in the early stages.
Mm-hmm. Yes, sir, back there.
I'm Bob Rohr with BMJ. A lot of talk has been made about abstinence-only prevention funding, and as Representative Lantos said, he's trying to work to free up that funding in some ways. Had there been any estimates or modeling done in terms of what has been lost, or the cost of misspending funding on abstinence-only programs and the benefit from freeing or changing these programs, particularly in the international setting?
I can say a little bit about that. I think the answer to your full question is no. It doesn't mean there hasn't been research in this area. There's been a lot of research on the impact of abstinence-only programs, but the results are mixed. Some show an effect, some show no effect, some show perverse effects. Part of the reason is that it's very difficult to define an abstinence-only program. It's not like voluntary counseling and testing, where you know what the intervention is. You know that the person received a certain amount of counseling and then received a test and a result, or a condom distributed. With abstinence-only education, what about the intensity of the interaction, the messages transmitted, the setting? So there's all these different things that can affect it. So we can find studies, we can find interventions that had no impact, maybe because they were done poorly, and we find some that have had an impact over the short term. Overall, we've not yet been able to put this together into an overall picture. I think everybody is hoping that the huge amount of money that's been spent on abstinence promotion in Pepfar will increase the research base here so that we'll have a better knowledge of how effective it is and how to do it correctly. But I would say we're not there yet.
I've been handed a question, I guess this came from the overflow crowd, which is, where is the role and the costing of prevention as a way to prevent catastrophic costs? I talked primarily about different ways of paying for health care so that the same amount of spending or more wouldn't imply catastrophe for people. And this question asks, well, how about preventing some of these needs in the first place? And certainly more can be done there, because as far as we can tell, hardly ever, if at all, does anybody have a catastrophic expense for a preventive activity. It just doesn't happen very readily. We don't know the details of what people were suffering that were surveyed in these surveys, but we can be pretty sure that it was almost always treatment. What we don't know, and this is important, is the difference between acute conditions and injuries and chronic conditions. The timing of this is very important. But there certainly is an argument to make that if publicly financed preventive activities were more successful and more widespread, they would cut down somewhat on the need for catastrophic spending. That's certainly true. I don't think that's the only thing you'd want to count on, though, because not everything can be prevented, whereas everything can be financed in a fairer and more prepayment way. What you can say is that better and more effective prevention would cut down somewhat on the need for this. Without knowing the details of what it is that people were sick or hurt by, it's hard to know what would be most effective. And prevention isn't always more cost effective than treatment. The argument that an ounce of prevention is worth a pound of cure assumes a 1:16 ratio, which just doesn't always hold up economically. So yes, more of it, but no assumption that that's the panacea.
Yes, sir. Thank you.
David Bryden with Global AIDS Alliance. Just had a question. Congress is beginning to consider the next phase of Pepfar, the President's Emergency Plan on AIDS Relief. And the President proposed a $30 billion level for AIDS, TB, and malaria over a 5-year period. I wanted to know if you thought that was a good idea or not, if Congress should accept that proposal. As Interaction said, it represents actually a flatlining, right, a plateau, not actually an increase at all over the next 5 years compared to current levels of spending, even as the epidemic is increasing. And other experts like Fitzhugh-Mullen and others have advocated a $50 billion package that would include health infrastructure spending, healthcare worker salaries, recurrent costs, and others, so that the package would actually be expanded to have more of a holistic impact. There's a broad coalition, our group and others, who are advocating that kind of an approach. So I wanted to know if you had an opinion about that, the President's proposal.
Do you want to say
It's all coming to you, John.
Well, first of all, I think we should say that the current Pepfar program and the Pepfar 2, if it gets authorized, I think it's a tremendous contribution. And countries where I've worked, where I've seen that up to 85% of the money spent on AIDS is coming from Pepfar in many countries. And as Representative Lantos mentioned, over 1 million people on ART. All have friends and colleagues that are alive today only because of ART that's available from Pepfar and other places. So it's a major contribution, and 30 billion is a big number, and it's more than currently being spent, so it's good. Could we use more? Absolutely. With UNAIDS is currently finishing up its new estimate of the global resources required for between now and 2015, and the numbers are larger than are going to be available through Pepfar and through other sources, as you might imagine. Focusing additional resources on improving the health system is clearly needed. There's no question about that. Healthcare workers, infrastructure, it's a strong need. One question for us, though, is that we probably also have to broaden the question beyond health. Suppose we had a lot of money to triple or quadruple health worker salaries. That's a good thing, but is that going to then draw teachers to give up teaching and go into the healthcare field to get the higher salaries? So just like we don't want to just focus on AIDS when we see all these other health requirements, we have to be careful about mainstreaming AIDS and ignoring the other development requirements, I think. So it's a tricky thing. More money for the Pepfar program, closer to 50 billion, certainly would be welcome.
Could I add something to that? There's a general tendency, economists have won the battle and lost the war. We've persuaded everybody that money matters, and now all we talk about most of the time is money. The really hard discussion here is the one that was alluded to in your question, which is distributing things across different diseases, and even worse when you're talking about health versus something else. That's where, in theory, we should always be using cost effectiveness as one of the main guides, if not sometimes the only one, to how to allocate it. And it is very hard to do, particularly when you have interactions like between AIDS and TB, or when you're trying to decide between prevention and treatment. It's just not easy. The Disease Control Priorities Project, published in April of last year, the most thorough compendium anybody's ever put together of cost effectiveness estimates to try to get the world to think harder about making decisions on that basis. But even within the choice among malaria, TB, and AIDS, there is no very simple answer. And when you start thinking of interactions, it gets harder. As was mentioned, for example, when you treat, do you make prevention easier or harder than before? These are awfully dynamic questions.
Amanda, you want to address that question?
Somebody is asking, did our study compare the effectiveness of money spent on research for new treatments versus money for more effective distribution of current treatments? And the answer, unfortunately, is no. We just looked at how money was distributed amongst countries and within countries in terms of disease control or condition interventions. And I would say, just adding to what Phil said about the disease control priorities work, is that we tend to look at cost effectiveness within a disease control priority. So there are great models developed, for example, on how to allocate within a malaria program between bed nets and treatment and environmental control, but not as much between different kinds of interventions that make it into the package of healthcare that a government or a country provides. So more work is required on that. And, the debate on whether we should be focused on new treatments versus using our existing armament is a debate that's really raging and perhaps not addressed enough, because our major funder in this area of research and development for new treatments tends to be the Gates Foundation. And it's difficult to make those kinds of trade-offs, because what if you do get an efficacious AIDS vaccine? What if you do get an efficacious malaria vaccine, and that's a game-changing technology? But it's all hypothetical at this point. But it's really hard to make those choices. We're fortunate we have private financing for it.
John, you want to take one of those?
Yeah, actually I have two, but one of them I can address pretty quickly. The question is it assumed in the model that the application of a vaccine means we don't have to provide ART anymore? And I think maybe I wasn't completely clear. No, we assume that ART needs to continue for those people who are currently infected. But when I talked about the savings from ART, I meant that if a vaccine prevents new infections, then there's no need to provide treatment for those people because they've never become infected. But you would still continue your ART program for those who are already infected and those who become infected in the future. The second question was, how did the model estimate, take into account the effects of behavioral disinhibition? What this question is getting at is, suppose I go to a clinic and become vaccinated with an AIDS vaccine. I now assume incorrectly that I'm fully protected and I can go back to my old risky ways. That's behavioral disinhibition. If people do that, it will to some extent counteract the effects of the vaccine. Even more pernicious, however, would be I haven't been vaccinated, but I'm assuming that everybody else has. So I can be protected through herd immunity, essentially, and I can go back to my old risky ways. Clearly, there is the mathematical possibility that if people adopt worse behaviors than they currently have because of the availability of vaccine, that you end up making things worse. But we don't think that that's likely to happen. What could happen is that people who have changed their behavior to safer behaviors would in some way revert back to some of those riskier behaviors. But that would only happen among those who've already changed their behavior, which unfortunately is probably not the majority. But secondly is that we do not think that a vaccine, when it becomes available, would be just a simple shot that you would give to people without any counseling, without any support. And we also believe strongly that all the other prevention activities currently ongoing should continue. The AIDS vaccine does not replace our other prevention efforts. It's another approach within that whole scheme of things. And the ART also, the intensive counseling and health system contact that goes along with ART treatment provides opportunities to continue that message. So while this is a potential problem, we believe that through appropriate implementation of the vaccine that we can address this. Yes, sir.
I have a question back there.
Oh, okay. Why don't we go back here for a minute?
Thanks. Tom Glynn, American Cancer Society. And this is for Amanda. You mentioned the growing number of donors that are in a number of countries. Cambodia specifically is in your example, the multilaterals, bilaterals, the NGOs. And do you have any suggestions for traffic control that would help make best use of those donor dollars or donor funds?
Yeah. Thank you for that question. Right now, we're seeing everyone everywhere, and I guess my main suggestion is that the bilaterals start really channeling their funds through the multilaterals, through the global health partnerships, and away from their micro programs. There seems to be still a great value in planting your flag in every country. So how can we, I've been trying to think, how can we give the political benefit of flag planting while still getting the money to work in a more rational way? And I think that a lot of the proposals that are out there have to do with coordination and with moral persuasion through the OECD. I think we can see that since things have gotten worse since the OECD decided this was a problem, it's not getting better. Those sort of voluntary, it would be nice kind of mechanisms aren't working very well. So one of the things that we're working on as Brookings is how could we develop financing mechanisms either internationally that complement the global health partnerships or within countries that would encourage pooling that might be off budget, because lots of the problems are that donors don't want their money going through budgets because they're concerned about public expenditure management, but that would still have the same effect somehow. So that's what we're working on. I don't have an easy answer, but.
Can I add something to that? There are actually two very competing ideas about how to simplify this. Both of them would probably involve some pooling, but one is that all the aid agencies agree to get together and send one mission instead of these dozens or hundreds of missions. It must absolutely wear people out in government to have to deal with these visitors all the time, so that they would agree to coordinate. But there's another model that says they should put their money in a common pool, but then for the administration of aid, for the actual delivery, they should compete with each other. The government should be able to say, I like your plan better than yours. You please go away, but leave your money in the pool. If it isn't pooled, then the competition wouldn't work because so many of the amounts of money are too small. But the argument that governments have a very hard time getting what they think they need done, actually done, would get worse if they're confronted with a monopoly of aid donors, all of whom are together and saying, no, you either take this plan or we go to some other country. I bring this up because one of the items in this issue of health affairs is a review of Bill Easterly's book, in which he urges very strongly that The same agencies that are constantly preaching the virtues of competition for economic growth don't believe in it for a moment when it comes to actually delivering aid. And they should, in fact, allow countries more choice. He even proposes that maybe a government should be given a voucher for, say, $100 million, which it can spend with whichever agency it thinks will do the best job. But there has to be a $100 million pool for that to work, obviously.
There's a question way in the back, if we might, we'll get you.
And you've got two people that asked questions before who want to ask again.
Yeah.
Hi, I'm Jessie Lickstein, NIH. I had a question on what your view was of microinsurance plans as an option for protecting households from catastrophic healthcare spending, especially in countries where national healthcare is absent or ineffective.
It's a help. Any form of pooling, any form of insurance and prepayment is a help against the risk of having to finance everything out of pocket on your own. There have been some fairly extensive studies the World Bank's promoted, and some of these together with the Wharton School, on various forms of low-level insurance, community-level insurance, for example. The problems there are twofold. One is that a poor community, even pooling their money, doesn't have very much money, obviously. So for this system to work at a low enough level, you've practically got to have a subsidy. But you could have a subsidy that's fed into a community pool. That is to say, the community gets together, puts up a certain amount of money, and then government, even if it can't run a clinic in that village, can contribute to the pool of that money. So there is a channel here for having a highly decentralized insurance with a much more centralized subsidy, and that makes a fair amount of sense. There are experiments in a few countries of this. There's a volume edit, the bank published, just last year, I think, covering some of these schemes. And the evidence is not overwhelming, but it's somewhat positive. The other risk in small-scale schemes is if they're not distributed very widely, if it's everybody knows who else is in the scheme, then the problems of some people using, quote, too much, unquote, healthcare, spending too much of their share of the money could break the scheme down. The family that's chronically sick will end up eating most of the money, and everybody else will say, well, there's no point participating in this scheme because it's all going to them anyhow. So there are small-scale social interactions that would need somehow to be controlled. The subsidy, again, could help dampen down that effect, I presume. But it's certainly true that they could mitigate the effects of catastrophic individual level spending, and in that sense, they're probably to be welcomed.
Question for Amanda. I wonder if your study looked at all at what I call the moral hazard of aid. In other words, as global funding and foreign aid comes in, are Ministry of Health budgets going up or down, or is there sort of an adverse reaction as host governments are relying on external aid? Is their investment going down?
Our study didn't look at that, but I think the companion study does take a look at that, and they find that it's going up, but not as much as aid is increasing, which reflects that aid is fungible, obviously. So,
yeah, the companion study that Amanda refers to is one that we thought we'd like to present to you today, but it happened that none of the authors were available for this. That's the first paper in the issue called Financing Mission Unaccomplished. Actually, if you think about it for a minute, if you're a perfectly sensible government and somebody gives you $1 of aid, you would be crazy not to go back and look at your own budget and ask, do I maybe want to knock 10 or 20 cents off what I was spending? The assumption that an extra dollar is a full dollar doesn't actually make much economic sense if there's something else you could use it for. What you wouldn't want is dollar for dollar replacement. You get no gain out of that unless the aid is actually administered better than the government could do for itself, which is unlikely. Something in between is what you expect, and that's usually what you find, as Amanda said. In other words, $1 doesn't mean $1 more of spending on health, but it does mean $1 more of total resources for something most of the time. And the rearrangement is what a lot of the argument's about. What liberty does the government have to adjust, and how much should they do it? And that's particularly important when the amount coming in is larger than what they're already spending. You know, if you're spending $100 million and somebody gives you extra 10 and you knock off 5, well, that's not making a big difference. But if somebody gives you $100 million when you were spending 10, even if you adjust the whole 10 away, you're still basically taking the aid money. It's very dependent on the size of the budget.
Yeah, we'll take one question here and wind up.
the fungibility question sort of leads into things that are going on in Southeast Asia. Thailand has purportedly substantially boosted its military spending, and yet is still using compulsory licensing as, shall we say, leverage to get manufacturers of AIDS drugs to offer their drugs at less than cost. I mean, how do you control for something like that when TRIPS and World Health Organization seem as though they're rather intent on expanding the availability of compulsory licensing? And how do you address the potential disincentive for development of AIDS therapies and vaccines?
Go ahead, answer.
Well, I'm not sure I'm competent to answer that question. Some of the countries that are either using compulsory licensing or threatening it are, in many cases, some of the wealthier developing countries, Thailand and Brazil, but they are spending huge amounts of their own money to support their HIV and particularly their treatment programs. So I don't think those countries are using this necessarily in an unfair fashion. They're just not using it to just save money that they could easily appropriate. They are spending huge amounts of their own money.
Well, some of the reports indicate that Thailand, for instance, is trying to use compulsory licensing to get a hold of plastics, which, under the traditional notion of compulsory licensing, does not constitute a kind of crisis that can be used to justify compulsory licensing in the first place.
Yeah, I'm sorry, I don't know very much about that.
Yeah, we'll take one more question and then.
I've got one here, but John.
Oh, okay. Go ahead.
Bob, BMJ again. UNAIDS has made clear in the past the importance of political will upon the part of the host government in terms of effective programs. Fairly recently, the World Bank has come around to the belief of the importance of intangibles such as education, trust, rule of law, things like this in terms of development. How important should these factors be in terms of the international community in terms of allocating its assistance?
Well, I think our study found that this consensus in the literature that better governed countries that have higher levels of political will is expressed through higher spending. They are receiving a greater share of the pie in terms of aid resources. But I guess the question I have is, better governance means maybe you're better off to begin with. So are we missing out on a lot of the states where the needs are huge? And it's not 100% clear that better governance means better results in the health sector. That's something that remains to be studied.
I think that one's probably for you.
This is a question about whether the Millennium Challenge account is a model for Pepfar in the future and whether this will help with respect to pooling at country level. Well, again, the MCA is really allocating based on ex-ante conditions of eligibility. So it's a kind of performance-based aid that says, okay, you're eligible if you meet certain criteria. And by definition, they're meeting criteria that mean that you're more developed. So they have better governance. They're doing better on a whole range of measures. They're spending a bit more. So I guess my question with those kinds of allocation mechanisms is, are we getting to where the needs are greatest, or are we just rewarding, again, those that were already doing a pretty good job? Obviously, there might be some incentive effect in terms of, giving, you become eligible when you reach those benchmarks, but I wonder if the incentive is large enough to create that kind of response on behalf of governments. And I'm not sure whether that helps with pooling and donor competition. This is more a model where countries compete for a fixed pie based on who crosses the finish line first in terms of those baseline conditions.
Philip, could you say a word or two about several of the other major papers that haven't been...
We couldn't present everything that's in this what I like to think of as a pretty good issue of Health Affairs. They're all pretty good, actually, but this one's rather special because it's the first one under the Gates grant that John described at the outset. I just want to call your attention to the fact that we have been able here actually to present only 3 of the papers. There are no fewer than 11 papers that are either worldwide, global, like the ones we've been talking about here, or country-specific. We've got 5 country studies in here. The overall theme for this issue was finance. Actually, the way things have gone here of the presentations, we've heard a lot about AIDS, which was an important topic, but most of the other papers we haven't described to you emphasize finance. There is this other paper on aid. There's an interesting paper by Bill Savadoff on what's the right amount to spend on health, which does not have an easy answer, as you might guess. An interview with Paul Farmer about equity in health. These 5 country studies. One of those is about the Russian Federation. It's not primarily about financing health, but it is about economics and the economic consequences of deteriorating health in the Russian Federation. Patricio Marquez, who's one of the one of the authors of that issue, joined us this morning. And then we have also studies that are specific to finance on Thailand, Morocco, Brazil, and Turkey. If you have particular country interests, you certainly would like to look at those. I can tell you that we're planning another issue like this under the same arrangement with the Gates Foundation for this time next year. It will concentrate on China and India, and then we will produce at least one more in 2009. The topic for that's not chosen yet. That's too far ahead to see. But as John said at the outset, we are interested in globally related material all the way along. It doesn't have to go into these special issues. We are always hungry for manuscripts, even though we accept only a small number of them. If you have anything interesting to tell us, you know how to reach us. Thank you very much.
And thank you for coming as well.